Good afternoon, everybody. Welcome to the ECHO Foundation course in Palliative Medicine. First of all, we will introduce ourselves. So I am Dr. Sunil Kumar. I am the Additional Director of Random Institute of Palliative Sciences.
Anyone sports to vaccine?
Good afternoon.
Good afternoon. Palliative care, if you have multiple devices at the same place, maybe I would recommend you turn off one of those devices.
Good afternoon. Welcome to TIPS ECHO Foundation course in Palliative Medicine. I am Dr. Sunil Kumar. I am the Additional Director of Random Institute of Palliative Sciences and facilitator for this ECHO Foundation course.
Myself, Sheba. Basically, I am a staff nurse. I am the TIPS ECHO coordinator. Good afternoon. I'm Sumita. I'm project officer working in Palliative India.
My name is Rajagopal. I am a director of TIPS.
Hi, I'm Dr. Amrita, palliative care physician, TIPS.
Myself, Gayatri. I'm staff nurse.
And in the back, you can see someone else. This is Susie. She's a nurse from New Zealand. So, can you introduce yourself?
Hello. I can't see you all. I can see one of my companions only on the screen.
Madam, you are saying that you cannot see all of us at the same time. Is that what you are
No,
saying?
I cannot see the speakers.
You are seeing only a black screen when we speak.
No. I am seeing one of my companions, Sister Catherine.
Maybe you have selected the icon. Ma'am, you can hear us, right?
Yes, I can hear you.
I think maybe you have selected an icon which just shows that particular person.
Yes.
Just
So what do
there is an option on the side where you can see all of them. Speaker view, the top right side.
Top right?
Yeah.
There is gallery view.
Yeah, please click on it.
Okay, thank you.
Dr. Ankush, unmute Dr.
So when you introduce yourself, you just please introduce your name, place, and the specialty in which you are working.
Dr. Bindu Mol, can you start?
Yes, I am Dr. Bindumol George from Nagpur. I am a gynecologist.
Dr. Viji,
I'm Dr. Viji Paulos from Dayasar Hospital, Amravati. I'm a pediatrician.
Okay, someone named as iPad. So can you please introduce yourself? Yes, please.
Dr. Jinsi, can you please introduce yourself?
I'm Sister Jinsimol MA from Devigavaram, Tamil Nadu, working as a family physician.
Dr. Merle.
I am Dr. Sister Marley, MD Medicine, working in Government Medical College, Jagdalpur, as Assistant Professor in the Department of Medicine.
Dr. Annie Catherine Surya. Ma'am, please.
I'm Dr. Annie Catherine Scaria, working in MD General Medicine.
Ma'am, please.
It is near Indore, 70 kilometers from Indore, Madhya Pradesh.
So, Vivekan, Dr. Vivekan.
Yes, I already introduced myself. I'm a professor of OBGY at Pratima Institute, Karimnagar, and I visit Karunalayam at Kazipet as HIV/AIDS physician. I did HIV/AIDS medicine from CMC Vellore. That is my introduction.
Thank you.
Dr. Lucian.
I'm Dr. Lucian, St. Mary's Hospital. I'm a gynecologist.
Ma'am, please.
I'm a gynecologist in St. Mary's Hospital in Malur.
Dr. Jawan.
Dr. Joanne.
Hello.
Yes, please.
Yeah, I'm Dr. Joanne. I finished my MBBS. I'm working in Snehadan and HIV and Palliative Center in Bangalore.
Sister Divya.
Dr. Manchu.
I'm Dr. Sister Manchu Rose from West Godavari district, Andhra Pradesh. I'm a family physician.
Sister Sudeepa.
Yeah, I am Sister Sudeepa, working in Pratyasha in Medsel district as administrator of the Palliative Care Center.
Dr. Ankush.
Dr. Ankush. Sir, we can't hear you.
Myself, Dr. Ankush Gotawale, working as a medical officer in Primary Health Center, Chandrapur district, Maharashtra.
Sister Divya, have you joined from 2 devices? You can see 2 devices in your name.
No, I had actually, it was laptop wasn't open, so I had opened my phone.
Okay. So please introduce.
Just try.
Okay, ma'am, please introduce, ma'am.
I'm Dr. Sister Divya.
Okay.
Working in Central Health Center in Jharkhand.
Jacqueline.
Dr. Jacqueline.
Dr. Shaili Moore.
Dr. Shaili Moore. Dr. Shaili Moore. Please introduce
Can
yourself.
you hear me?
Yes, we can.
Can you hear me?
Yes,
Yes.
we can.
Okay, I am Sister Catherine or Shiny Mod, working in Assisi Hospital near Vijayawada, 70 kilometers away from Vijayawada. I am a general surgeon.
Is there anybody else to be introduced? With system early, I see there is one more person.
Ma'am, please.
I'm Sister Lal.
Sorry, ma'am.
Yes, please.
I am Sister Liza, working in Holy Cross Community Health Care Center, Tarwa.
Hello.
Which
place?
Ma'am, which place?
Tarwa, it is Jharkhand.
Okay.
Hazaribagh.
Okay.
Dr. Merli, is there somebody else with you to be introduced?
Yeah, that was Sister Valsala with me.
Okay.
Dr. Sister Valsala, psychiatrist.
Okay, thank you.
Both of us are working in the same medical college,
Okay.
Jagdalpur Government Medical College. Okay, she has some problem with the connection.
Okay.
That's why we are sharing the same mobile. Okay.
Okay.
Thank you.
So before going into the session, yes.
Is there anybody left out to introduce? Please raise your hands. Okay.
Biju.
Please.
Group. Rajagiri telemedicine.
Right. So please unmute yourself, sir.
Yes.
Please go ahead.
Can you hear me?
Yes.
Good afternoon, sir. Nice to see you. Hi, Sunil. And I see Susie in the backdrop. Yeah. And I'll just introduce fast my teammates. Can you come in the back, please? Can you come in the back? So this is Sister Simi. She's our palliative care nurse. And right behind me is Mr. Alvin. He's our social worker. Next to Alvin is Mrs. Veena. She's Miss Veena. She's our social worker. And at the far end is Mrs. Shiny. She's our nursing assistant. And we are glad to be part of this. It's at very short notice. We're very glad to be part of this.
Thanks, Vijay. So before going into the session, I would like to tell you some rules regarding echo. So whenever you are not speaking, please mute yourself. Otherwise, it will be disturbance to others. So whenever you want to speak, just raise your hands so that we can unmute you. So today's session will be by Dr. M.R. Rajagopal. He is the director of Trivandrum Institute of Palliative Sciences and chairman of Palliative India. So before going to the session, we have a pre-test. We have some questions which will be, you can see on your screen, so that when we launch the questions, you have to tick the right one, and when you finish all the 10 questions, just click the submit button, so that it will be submitted. So all of you, please try to answer these questions. I hope all of you can see the screen now with questions. Vijay, can you see the questions? This is an anonymous one, so it's not a problem for you. So just there is your name is not written, so you can click the right answer and submit the click the submit button. Can you see the questions? If you can see the questions, please raise your hands. Okay. I hope you are doing the questions now. Any of you can't see the screen?
Do something.
Only one person has completed. I request others to complete, please. We have only 2 minutes more, so please be fast. Only 1 minute remaining. Please be fast. I think 2 or 3 people more need to be completed. Fifteen has completed now.
I'm Sister Sajita Mary John. I could not connect it on time because of some error. I
Okay.
did not hear the question as well, so I am not able to answer.
The questions are launched online. You can see it in your laptop or mobile. I think now we are going to finish the online questions now. Yeah. Now we are stopping the online questions and we will go to the session right now. Thank you. So once again, I welcome you to this course. There will be total 18 sessions. And the first session is on Introduction to Palliative Care by Dr. M.R. Rajagopal. So I am handing over the session to Rajagopal sir.
Can you all hear me? Am I audible? Please raise your hands if you can hear me clearly. Thank you. Thank you for being here. Some of you are very senior clinicians. The collective experience, clinical experience of this group must run into centuries. There are professors, specialist doctors, also some young doctors. At that level of clinical experience, being willing to learn a new thing, attending a classroom like this, that is really admirable. I want you to know that I have great respect for your willingness to be a student again and learn these new things. Thank you. I was trained as an anesthetist. I started treating people's pain, and that's from where I ventured into palliative care. But that is just to introduce myself, and now I want to introduce to you somebody whom you cannot afford to forget. Dame Cicely Saunders was the founder of the modern hospice and palliative care movement. I think she opened a door for us. We are still growing. We are finding new avenues to explore it. Cicely Saunders was a nurse. As a nurse, she started caring for people who were dying of cancer. Eventually, she had a back problem. She could not lift patients. So she stopped nursing, became a social worker, and continued to work with people who were rather abandoned by the medical profession. She found that cancer patients near the end of life were abandoned by the medical system. She tried to get doctors to see it, but she met with a lot of resistance. Now, why am I saying this? Cicely Saunders found pain and suffering, wanted to relieve it, but she was not welcomed openly. I think all of us should be prepared to cope with that kind of resistance. This is very likely to happen to everyone who is arguing for a change. At a certain point of time, Cicely Saunders was told by a senior doctor, go and read medicine. Unless you are a doctor, no doctor will listen to you. So at the age of 34, I think, she became a medical student, became a doctor, and continued her work till she died, maybe something like 15 years back. The hospice that she first founded in 1967, the St. Christopher's Hospice in London, continues to be a major learning center for palliative care. So, hey, before I go on, I hope everybody is able to listen to me, to hear me. If anybody is not able to hear me or follow me, please raise your hand. Okay, I hope everybody is. Thank you. What is palliative care? You all answered some questions. You may have different ideas about it. I already told you, Cicely Saunders started treating terminally ill people with cancer. That's how it started. But that was 1967. The field of palliative care has evolved. Today, it is not exactly that anymore. Let me tell you this story of this child. When we went into the children's palliative care clinic from a distance, we could hear this child's screams. The child was not having cancer. The child had severe muscle spasms following an encephalitis. It left her with sequelae, and she had the pains caused by muscle spasm. And then she developed pressure sores. She was a ball of pain. Along with that, naturally, because more than 3 months, the father had to leave his job. There was no income. They started borrowing money. After seeing the child suffering for a while, the mother herself started behaving abnormally. When we saw her, she was standing like a statue in a corner. This young girl that you see there, who is looking after the child, she was, say, 10 or something like that. She was officiating as the mother. She was explaining to her what was happening. I asked her, so if the baby is sleeping only for 15 minutes at a time, when do you sleep? She said, I sleep when my sister sleeps. So this major caregiver was also able to sleep only for about 15 minutes at a time. Can you imagine suffering like that? I know everybody in your clinical practice has had patients. Many of you may not have seen them in this condition because currently somehow we are able to tell them there is nothing more we can do, go home. Not everybody, I know, but many hospitals do that. The father later confided to me that the family as a whole, he was planning to kill his wife and 2 children and then hang himself. That was his plan. What is it that healthcare system should provide them? Can you please tell me? if we call ourselves healthcare professionals, what is health? Not only absence of disease, but physical, social, and mental well-being, right? So what should the healthcare system? The healthcare system includes you, me, all the employees and whoever works in the hospital, the hospital administration, maybe the health minister, that system. What should we do for them? I wish there was enough time for interaction, but that's the problem when we have a large group like this. But would let one person please raise your hand and tell me what should we do? What should be the responsibility of the healthcare system? Somebody please speak up. You raise your hand and we'll unmute you. Dr. Johan, did you want to speak? Dr. Vivekanand.
To provide emotional and psychological support to the family, sir. Hello?
Dr. Vivekanand, maybe the first few words were not audible because we hadn't unmuted you. How did you start? Certainly giving emotional support to the patient and family.
Psychological support, yeah.
Yes, yes. Anything else we can do? What can we do for the baby?
Holistic approach, team approach.
Sister Sundeepa has something to say.
Physical support plus the spiritual support we have to give to the family.
Absolutely. Absolutely. The World Health Organization's definition of health does not include the spiritual domain, but they also need spiritual support. But sister and Dr. Vivekanand.
Yes, sir.
With the baby's name.
Yes, sir. That's what I said. Team approach. You provide the team, holistic team approach to her.
Okay. What Dr. Vivek, let me try to explain what Dr. Vivekanand means by that holistic approach. Well, that term is usually used for looking at a person as a whole.
Yeah.
The current problem in our country is that pain is not treated, except with almost superstitious beliefs in some medicines. Let me tell you what was done to this child. This child got morphine. The child was only a year and a half old. Can we give morphine? The answer is yes, morphine can be given at any age. Naturally, you have to know how to start it and go about. This is not the time to discuss the dose of morphine. But that child, in that kind of agony, needed play. My primary focus of care is that baby. It's also the family, as you rightly said, the family. But palliative care is treatment aimed at quality of life of the patient and the family, of the person with a life disease and the family. Receiving about 2.5 milligrams of oral morphine 5 times a day. The child, do you think the child would have been unconscious with that morphine? By no means. The child actually had started drinking and eating a little bit. The child we found also had candidous throat thrush because of poor immune status. We treated that. The child lived rather pain-free for about 3 months and eventually died. But as you pointed out, the holistic approach was making sure that the father got back to his job. He had lost his job, so somebody had to ring up the employer and plead to him, look, this was what was happening to the child. Please give him his job back. It worked. Doesn't always work, but it worked. We made sure that the mother was seen by a psychiatrist and appropriate treatment was instituted. She is back being a mother now. And most importantly, the sister got her childhood back. She is back in school. No, every patient is not like this. Every suffering is not like this. But what I mean to say that ordinarily the hospitals, as Cecily Saunders found at that time, ordinarily we concentrate on the disease, encephalitis. We treat encephalitis. That child had got aspiration several times, developed pneumonia. Every time the child was put in an ICU. And from the intensive care unit, the child would come with the pneumonia treated and with a new pressure zone. We concentrate ordinarily on diagnosis and cure. And if cure is not possible, we generally do not learn in medical school and do not teach in medical school what can be done. Doing all this, the holistic approach, as you said, that is looking up to the physical, psychological, social, and spiritual domains of life, assessing the problems in each part, treating what you can, and improving quality of life is palliative care. With that, I am raising a question to you. Is this statement correct? You see the statement on the screen? Anybody raise your arm? Dr. Sudeepa?
It's not correct.
Thank
It's
you.
wrong.
Dr. Sudeepa, would you like to add a couple of sentences or two? Why it is wrong and what is going to be correct?
Palliative care center, just now we have finished, it is a holistic approach to the family. It's not only the patients suffering with the cancer and death. It's to the whole family whom we have to give care.
Absolutely, okay. It's for the family. Family of patients with cancer and AIDS alone?
No.
No. As Sister Sudeepa says, that kind of discrimination should not be tolerated. Whatever the diagnosis is, if there is serious health-related suffering, that needs to be treated. That needs to be treated in the patient, that needs to be addressed in the family also. This is the official World Health Organization's definition of palliative care. Because it is too long, I have shown some phrases in red. It's about quality of life. And as you all said, not only the patient, but also the family. In people with life-threatening illness is what the World Health Organization says. This was 2002. They have not modified that yet. But in 2017, a Lancet commission brought out the focus of palliative care as, I repeat, serious health-related suffering. The definition talks about prevention and relief of suffering by assessing and treating physical problems like pain, breathlessness, vomiting, bowel disorders, fungating wounds, whatever that is. But also psychological problems, the depression, the anxiety, the fear, the guilt, social issues. Don't we all see sometimes at some stage of life, some families abandoning patients? But that may be rare, but what's commoner is a distance developing between the patient and the family. They show care for a long time. Eventually they get fed up. We give a respectable name for it, compassion fatigue. There's also the stigma, especially against some diseases. I know of families of somebody with cancer where a marriage that has been fixed for the daughter was cancelled because it is a home with a bad disease. such stigma, the isolation. The 93-year-old man who came to me this morning said his biggest problem was there was no one for him to talk to. That kind of isolation. But also spiritual. Now, most of you are working in a very spiritual environment. And I would just like to add something. If someone doesn't believe in God, atheist, can he still be a spiritual person? Can he still have spiritual pain? Okay, my own answer to that is spirituality is about what connects the person with the world. For many of us, it is God, our faith, our religion, our religious rituals. All these seem to connect us, grounded to the world, but not for everybody. Some people are connected to their environment more. They may not believe in the conventional idea of a God, the creator. They may say that, well, anything good is to be respected and worshipped. Whatever that is, whatever is connecting that person to the world. And there, particularly to the young people, think twice before you take your elderly parent or grandparent away from their village to live in a 25th story apartment in Mumbai. They may get totally disconnected. The same thing happens to people who are put in intensive care units, disconnected with their world. Those of you who do intensive care would recognize that a lot of patients get disoriented. That kind of disconnection is also part of spirituality, and treating that is also part of spiritual care. Also giving the person a meaning and purpose to life. Spiritual care involves all of these. I have a few more minutes to describe what I think is palliative care. But about what I have said so far, does anybody have a question?
Please raise your hands if you are having a
As I said earlier, this palliative care should be made available for anyone with any serious health-related suffering. So when should it start? Could you have an answer to that? When should palliative care start? Suppose somebody is diagnosed with a life-threatening disease and has serious health-related suffering. It started 1 year back. When should palliative care start? Sister Sudhiba? Third row center.
Beginning itself, we can start the palliative care.
Sorry? Sister, please repeat that. Sister Sudhiba, please repeat it.
Yeah, we can. When we diagnose the patient is having some serious sickness, and from the beginning itself, we can start the palliative care.
So, thank you, Sudhiba, sister. It is not only for the dying people, it is not only for the incurable ill, it is, as the World Health Organization says, it's applicable early in the course of illness also. In conjunction with other therapies, you do your chemotherapy, even if the disease is curable. If there is serious suffering, you combine it. Now, we sitting here now are doing only palliative care. But you are ideally suited to help patients because the gynecologist or the general medicine person or the GP, you when you incorporate the principles of palliative care into your overall management of diseases, that is the ideal time to start palliative. This was the older concept earlier in Cicely Saunders' time and thereafter. Curative therapy was given for a long time, and palliative care or end-of-life care was given only in the end. Actually, the World Health Organization had defined palliative care like that, as to be given when the disease is no longer responsive to curative treatment. Let me repeat, this is not what we recommend. This was the old thing. What we would recommend is palliative care going along with curative treatment or remissive treatment. Whatever be the disease, application of principles of palliative care along with disease-specific treatment. And you see the green triangle in the end, because palliative care is not only for the patient, but also for the family. Support for them to cope with the grief of the loss is also part of palliative care. This is what we try to do, but especially because we are in a standalone palliative care unit, you are in an ideally suited position to do this, to give palliative care along with disease-specific treatment. Any comments? Oh, I've been speaking too long. Any comments on this? Okay, my colleagues are asking me to stop. I promise to stop in 5 minutes. Now, we should know some recent developments. The World Health Organization Assembly is the decision-making body of the World Health Organization. In 2014, passed a resolution asking all member countries that palliative care should be an integral part of all healthcare. And the Pope, over the last many years, has repeatedly argued for palliative care. The Pope in 2015 says, palliative care may not be cured, but it does not become any less important. He has asked us all to integrate palliative care into healthcare. So there is global agreement that palliative care should be integrated into healthcare. And that equitable as necessary, available to everybody, should happen in the continuum of care, as you said, from the beginning of the suffering to the end, across all levels of care, meaning primary, secondary, and tertiary levels of care. So the big corporate hospital doing cardiac transplantation, as well as the ASHA worker going into people's homes, should all integrate palliative care in their practice. This is what we will try to do. We already said, looking at the social, physical, emotional, and spiritual the domains of life, make an assessment, especially patients whom we see may not say everything for the first time. But when somebody seems to be suffering a lot, what I would do is When the face tells you, okay, how are you? They will say, okay. But if they don't look okay, I may sit beside them and say, but your face tells me that you are worried about something. Please tell me what it is. When my time comes, I will stop here and start the case presentation or further discussion after taking your question. But when my time comes, I am hoping for my doctor would have all this. I certainly want my doctor to be knowledgeable. All the science that has been drilled into your head, I want that. But I would also want the doctor to have a little bit of the heart. I know when I am very ill and suffering, if a very serious looking, ferocious looking doctor, unsmiling doctor comes to me and asks me, what is wrong with you? I will say, I'm okay, doctor. Whereas if you sit beside me, give me a smile. If you lay a hand on my hand and ask me, you seem to be suffering, how can I help you? Then I will open my heart to you. Because then I will know you care for me. So with Sunil's permission, I will stop there and take any questions that you have.
Thank you, sir. Briefly, what sir was talking about was the basic components of palliative care. So there are some new concepts has been introduced. Previously, we were all talking that palliative care is for chronic diseases, or palliative care was diagnosis based. But as per the new Lancet Commission report, it says palliative care can be given to any serious health-related suffering people. So, any people with serious health-related suffering can be given palliative care. Palliative care, the founder of modern palliative care is Dr. Dame Cecily Saunders, and she started St. Christopher's Hospice in 1967 in UK and introduced the concept of holistic approach, which include physical, psychological, social, financial, and spiritual suffering of the patient. So palliative care is otherwise called as total care because it takes care of all these components of suffering. And World Health Assembly has said that palliative care is an integral part of healthcare system. So, sir also told that any doctor or any person who is working in palliative care should have good heart, hands, and head. So skills, compassion, and knowledge. This should be there. And palliative care does not end with the death of the patient. It also extends as a for support for the family as bereavement support. So these are the points that we discussed just now. And the session is open for discussion now. So anybody want to comment or ask questions, please raise your hands so that we can unmute you. Yes, Dr. Merlin.
It was a very good introduction, and understood that palliative care begins from the diagnosis till the death and continues till the bereavement of the family. And it is a part of our whole care and support of the patient. WHO has made it a point that every doctor should know what is palliative care. Thank you so much.
Thank you, sister. Sister Bindu.
Hello.
Hello. Thank you, Dr. Rajagopal, for your introduction. I have a question. Do we need any special recognition or permission in the hospital to have palliative care for the patients who come to us?
Doctor, no. We do not need any special permission for starting palliative care. But one important medicine that you must have is morphine, oral morphine particularly, both injectable and so-called essential narcotic drugs. Now, for that, you would need approval from the drug controller of your state. This is in addition to any other state rules that you may have. In most states, you need a permission to start any nursing home anywhere with the inpatient facility. That varies from state to state. But to start palliative care, no. Very clearly, no. No special permission is needed.
Thank you, sir.
Sorry that we cannot offer you tea online. Mercilessly, I am going to have it. Any other question? Mr. Valsala.
Good evening. I'm Lisa.
Oh, Lisa. Okay. Hello, Lisa.
Okay. Many of the patients, when we offer palliative care treatment, they expect financial support and everything to be given free. The expectations of the people are different than when we integrate this into. How can we manage with such situations?
I hope, Sister Lisa, that you will come over and visit us someday. Now, we all have the problem. Every year in our country of India, a very recent statistic says that 55 million people a year are pushed below the poverty line because of cost of treatment. One MRI scan and then the family cow is sold, and then second MRI, the surgery, they are wiped out, and the next generation is also destroyed. So this is a reality that we have to face. When I started palliative care some 30 years back, I used to write prescriptions, but they would not take all the medicine. How can they when they don't have money? So we started raising funds to give free medicines for those who cannot afford to buy them. That's one thing we did. Then we found that sometimes they take it thrice after food. There is no food in the family. And it is absurd for me to keep giving them tablets if they do not have food. So now, for those who are below poverty, those who are likely to starve, we put kids in. I believe our healthcare will be complete healthcare only when we are able to face that. That means raising resources from the community. That's our main source of income.
Thank you very much.
Dr. Lucian?
What do you speak about home-based palliative care?
So, Dr. Lucian, I'll tell you what we do. We believe that as far as possible, people should stay in their own homes where they feel connected. You know, most of us would not be in a hospital by choice. But if they are able to get into a bus and reach us, we expect them to come to an outpatient clinic. But if they are too ill to come to the clinic, then we start providing home visits. Only if we cannot give them relief in their home settings, only then we get them in there as inpatients. This is our routine. So and so is unable to, is in suffering, unable to reach us, we have to reach them. It's as simple as that. Maybe there are more questions, but we have to get into this. Let's go on with the case presentation. And at the end, maybe we'll have more time for interaction. But to everybody who asked questions or made comments, thank you very much.
So Dr. Bindumal will be presenting a patient story. I request Dr. Bindumal to please proceed.
Can I start?
Yes. 1 second, I will just share the screen. Yes, ma'am, please, sir.
Good evening, everyone. My patient is 84-year-old female, unmarried, living in a nursing care home. Her presenting complaint was unconsciousness for 3 months. History of presenting complaint. Patient is a known case of dementia with loss of memory. She was apparently well and moving about since 3 months ago, when she gradually developed weakness of her right upper limb and difficulty in getting up from sitting position and difficulty in walking, and that gradually progressed to loss of speech and inability to swallow. Past history, she is a known case of dementia with loss of memory, diabetes mellitus and hypertension, on medication for many years. Family history and treatment history was not significant. Personal history, sleep and appetite could not be assessed since the patient was not responding. Bowel habits were regular. Bladder, there is catheter in situ. On examination, patient is lying in a airbed, propped up position, Riles tube in situ, catheter in situ. General condition is fair. Skin, hair and nails are normal. There is no ulcers or bed sores. No pallor, icterus, cyanosis or edema. Vitals were normal except for BP 140/90 millimeter of mercury. There was occasional eye opening to stimuli and slight movements of the limbs. Respiratory system, cardiovascular and per abdomen was nothing to be commended. 3 months back, she was taken to hospital where she was found the blood pressure was slightly raised. Blood investigations were within normal limit. MRI brain revealed that there is a large subarachnoid hemorrhage along the bilateral cerebral convexities. Neurologist consultation was done and they were given the option of surgical versus conservative management. Considering her physical condition and ability, the relatives opted for conservative management and she was put on medications and was discharged from the hospital for further palliative care. The diagnosis is 84-year-old female patient with known case of dementia, diabetes mellitus, hypertension, cerebrovascular accident with unconsciousness on palliative care.
So it's a 84-year-old woman who was diagnosed with dementia, and 3 months back she was unable to move her upper limbs, followed by lower limbs, and gradually speech was affected. On investigation, it was found to have subarachnoid hemorrhage, and family opted for palliative care. She was having rescue and Police catheter also? I don't know.
Yes,
She
yes, catheter.
She also has diabetes mellitus and hypertension. So, anybody want to have any clarification on this patient? So, if you don't need any clarification, we can please have your comments regarding palliative care in this patient.
Hello, good evening all. Sir, if she was unconscious, so is there any need for pain therapy?
I think this question, first of all, we'll try to answer by the participants, and then we will take the comment from the other person later. Anybody wants to comment?
Dr. Lisa.
Yes, Dr. Lisa, please.
Good evening. This patient basically need care, preventive care from bed sore and taking care of her hypertension. Was she sent with some medicines from the hospital from where she was referred?
The specific question was, should the person be given pain control? I mean, any pain management is necessary.
I think no. Since she is unconscious, she do not require pain management, I think.
Okay. Any more comments from anybody? So we need to give some analysis for this patient.
Does anybody in the group feel that some analgesia may be necessary? Sunil, shall I try to answer that question? Okay. Dr. Lisa, we have a problem here. Somebody who is not responsive may still be taking in sensory input. They may not, it's possible that they are unable to respond by ordinary expressions of pain. So that is a fact. Now, another point. When somebody is unconscious and doesn't speak, are you sure that they are not feeling anything? Fear, anxiety? We are never sure. That's part of it. Unless you are doing an EEG and finding straight lines, or unless you have a patient with brain death which has been proved, we will proceed with the assumption that they could possibly be feeling something. That assumption is good. I mean, so what would you do? I wouldn't immediately start dishing out morphine to every unconscious patient. That's not what I'm saying. But if somebody is already on painkillers and then they become unconscious, we assume that there may be pain which they are unable to express. So in those who are already on analgesics, it's better to continue it. But very often, when they are in that kind of state, their need for morphine may come down a little bit. So imagine a patient with cancer getting 30 milligrams of morphine every 4 hours. If they are unconscious, I may reduce the dose, reduce it by 1/3 and give only 20 milligrams. So that is for the patient who is already on morphine. Now, if they are not on morphine, then I will look for any expression of pain. Do they flinch when you turn them? Are the eyebrows furrowed? Is there any expression of pain? If there is, it may be wise to give a small dose anyway. But that is very empirical. You will do that case by case. So pain management maybe, may not be, but the more important thing is, unless it is somebody, as I said, who is brain dead or so totally unconscious, it may be a better idea to continue to talk to them. What I would do is, if there is an unconscious patient like that, when you go in, the nurse goes in the morning to change the position, we'll start by saying, "Good morning, how are you today?" What's the harm in saying that? We are going to turn you okay, and then turn. So at least if they have now some sensation inside, at least they feel there is somebody who cares for them. So that is a general rule. To repeat, pain management, if already on, you may reduce the dose of painkillers and continue it. If they are not on pain management, they may have new pains as caused by pressure sores, in which case look for expressions of pain and try to treat it. And always, unless they are totally and they are brain dead or having EEG straight lines, assume that they may have some degree of consciousness, say, and continue to talk to them. Continue to treat them as human beings, not like an inert body.
Any questions? Any more questions?
So far, there are a few young people in the group, just 2 or 3, right? All the questions came from the seniors. Hey, youngsters, please speak up. Oh, Joy, very
Hello.
good. Very good. Good.
Hello.
Yes,
Yes, I have a similar patient who's had a subarachnoid hemorrhage, and she's actually very spastic right now. So her limbs are in the flex position, and as such, she has no expression of pain. But when we try flexing or extending her hand, she shows wincing, and like she's completely, her hands are fully flexed, and even her legs. So right now, we don't know exactly how to treat that.
Joanne, unfortunately, that spasm has happened. And it can be painful. And what you are saying is, when you change the position or try to extend the limb, she has pain. Okay, we can only make assumptions. If the pain is only on forcibly abducting the limbs, do not give pain relief. But if the physiotherapist is going to come and try to abduct every day, better before the physiotherapy gives them. So it will be very empirical, Joanne. We never know. If you are in doubt, there is one thing that we can do. We can start some pain management. Maybe you may give simple paracetamol, I don't know. Or maybe a small dose of morphine, maybe.
Tramadol, okay.
You may try something, okay, tramadol. You may try something for maybe 48 hours. See what's happening. Does she seem to be better? Does she seem to be more comfortable? If she is, continue it. So you may try a therapeutic analgesic trial in some patients. But Joanne, thank you for the question.
So we were talking about physical component of palliative care in this patient, but how can we think? How can we include all the components of palliative care in this patient? How are you going to give the other aspects like psychological, social, spiritual?
So very quietly, my colleague Sumita sitting here is asking, how can you give psychological support to an unconscious patient? But Sumita, I already answered that question. If there is somebody seems to be unconscious, you don't assume that they cannot hear anything. Continue to give them love. The magic word is love. You don't talk about it in the medicine textbook. It is not fashionable. But what I would give is human love. And if there is some bit of sensation inside, make them feel cared for. I have a friend who is walking about and active now. He had a stroke. He was unconscious apparently for 3 months. But he was conscious. What he tells me, the worst thing in those 3 months is that nobody, including my wife, told me what was happening to me. I couldn't move, I couldn't speak, I didn't know what had happened. He says the worst thing was the anxiety that he felt in him because of lack of explanations. So, psychological support for him involves just giving care, giving love. We don't care if they are not receiving it. If it is not reaching them, well, maybe a little bit of love is not wasted. It does at least good to us. But also the psychological support of the family, needless to say. And socially, giving them some companionship, sometimes, just to make sure that if they are feeling inside, they feel they are in the society and not secluded in some other way. Dr. Bindumon, I have a couple of comments more about this patient. But first, can I make a request as tomorrow's patient? I told you I want your head, heart and hands, right? But I don't want you to treat me as a case. I'm not a case. I may be having a horrible tumor. I may have had 3 myocardial infarctions. But don't call me the case of myocardial infarction. I'm a person. So one of the things that we try to teach in palliative care, we don't call anybody a case of something. No, this takes a lot of time. It took a lot of time for me because till I was about 40 years of old age, I was also calling everybody a case of that or a case of this. But in our mind, we'll start thinking of them more as persons when we stop calling them a case of something and say 63-year-old Mary rather than a case of subarachnoid. 63-year-old Mary had a subarachnoid. That's one thing. Secondly, Dr. Bindumon, I want you to think. This is difficult. Very difficult question. Maybe I don't know whether I should bring it up now, but she has a nasogastric tube. Is that improving her quality of life? Or is it prolonging her suffering and stretching out the dying process?
How do we give the nourishment otherwise for a patient who is well other than her brain condition?
Okay, how do we give the nourishment? Very important question. If Dr. Vinod, again, think about me. When my time comes, if I have no hope of coming back to any reasonable quality of life, I have written an advanced medical directive that I should not be kept alive by artificial means. In which case, there is a big question there. If I choose not to have a nasogastric tubing, if I choose not to have an artificial feeding, you accept? Hello, sister.
Hello, hello.
Sister with Dr. Bindu Mohan. Glad to meet you.
If I feel it is against medical ethics not to give nourishment for the patient till they are alive.
This is a important question, and we all struggle with this. We at some point start with only pointing out some another argument also. Like, shall I argue against myself? As I said, if I have some level of conscious insight and I am hungry, I want that hunger set. That means that nutrition may be good for me. But if it is somebody already going towards that, the problem is we are stretching the period of suffering. So there are two sides to the argument. But it depends on whether it is ethically right or not. Depends on what's the overriding principle of medical ethics. We'll talk about it on another day. The first and overriding principle of medical ethics is autonomy. If when my time comes, I have made that note that in the context of incurable illness, I do not want my life prolonged by children. I hope you will be able to respect that. But I have not completed that existence. But very often there is a conflict here. The family also will be desperately worried and wants nutrition here. So there could be two arguments here. Yes, sister, you wanted to say something.
It is not termed as an incurable illness yet, and she is responding to the love and psychological support that is given. So she is not brain dead.
No. Brain dead.
My heart doesn't allow me to keep her starving. Do you think that we should starve the patient, or you think only rice tubes should be removed and IV fluids should be started?
No, in actual practice, let me explain. It may not be brain dead. If there is a neurologist and you feel that there is a possibility of recovery, no question, you should continue that nutrition. Absolutely. But it need not be brain dead. Sometimes, looking at the MRI, the neurologist and the radiologist will say, this is gross brain damage, there is no chance of recovery. Only in that case, that is the situation we are talking about. Now, even advanced cancer, say for example, a tumor here, even nasogastric tube cannot be controlled. The question comes, should we do a gastroscopy? Again, I would leave that decision to the patient. You have two choices. One, to have a gastrostomy and cleaning. The other is not to get nutrition, but to get only hydration. On another day, sister, we'll talk about it. It need not be intravenous. In palliative care, because intravenous continuous lines cause phlebitis, especially in some immunosuppressed patients, that may be a difficult decision. We may give subcutaneous saline to make sure that they do not get dehydrated, and dehydration does not cause suffering. These are individual choices. No, I am not saying that this patient should not have had a nasogastric tube. Only saying that that is something that we think about. Essentially, what we are doing is, I cannot deny nutrition. From that point, change to, I will do the best thing for this person's quality of life. If that quality of life is likely to be sustained by nutrition, by nasogastric intubation, that's fine. But the American Alzheimer's Society, in their guidelines, say specifically that in dementia, in advanced dementia, when somebody stops eating, the thing to do is to continue to persuade them to have a little bit. rather than nasogastric tube, because nasogastric tube induces the risk of aspiration. When you have a nasogastric tube in, the gastroesophageal sphincter becomes incompetent. Regurgitation becomes more likely. It is not an absolute yes or no. This is an ethical issue that's harder than many other ethical issues. And like in many ethical issues, there is no clear right or wrong. Just saying that there is another argument for us.
Thank you, sir.
Any more questions?
We have 5 minutes more. Did Dr. Lucian want to speak?
Not really, no.
Anybody else? Biju from Rajagiri, would there be any comments?
Actually, unfortunately, I could not be part of it. I had some patients to see in the OP. So I was there in the beginning part and I just came in a little while ago. So I missed most of it. So sorry, I was actually asking my team what all transpired. So very sorry, I could not be there full time.
So would your team like to ask a question, or do they have a comment?
I guess not, sir.
From the ECHO team, Anmol or anybody from the ECHO team, any comments? ECHO India? So Sunil says he's ready to wind up, and because we have a minute or two, I want to ask your feedback about the session as a whole. I know there were some problems, technical problems, some noise from our side, which was very disturbing, and some problems muting and unmuting. So whether about the technical aspects or about the session as such, would you have any other comments? No, about that I must ask for some feedback. Anybody who has not spoken to us so far, please speak. Was the technical problems insurmountable? Did you find the session helpful? Who has not spoken? Dr. Ankush, what do you think?
Session was very good. I could not listen sometimes due to the connectivity. After all, the information given by you was very important to run palliative care and our general practice also.
Dr. Sudeep, Dr. Ankush, thank you very much. I'm sorry that you could not hear part of it. I suppose you will be mailing the PowerPoint or the video. So the video will come to you. So I hope those who could not hear the whole thing will take a look at it and hear it. Anybody else? Sister Annie Catherine, we don't seem to have heard from you. Any comment or question?
Session was good, and I could hear everything. I had no problem with the connectivity.
Thank you.
From the discussed patient story, the opinion is regarding pain management is if the patient expresses or if there is any facial expression, anything that in case the patient has pain, then we will some analgesic. If the patient is already on some analgesia, we have to continue the analgesia and you may decrease the dose. If the patient has some flatline in EEG, then you may not give any analgesic. You should treat the patient like that patient wants, so that the dignity of the patient is maintained. Whenever you do or perform any procedures on the patient, you have to explain to the patient so that even if the patient, he can see that the patient may be. So it is very important to explain each and every procedure to the patient. The therapeutic touch is very important. Psychological support to the family in this patient is also important. Regarding the nasogastric tube, that was a very good discussion, whether we should need or the patient need or not the nasogastric tube. But the essential component is what was in this patient, she was unconscious. So we don't know what was the patient likes and dislikes. We can discuss it with family. If the patient was, if she had expressed any view that if she becomes unconscious, or if she is in a condition which from where she could not reverse in that condition, but she would have liked, whether she wanted an OX tube or not, should be discussed with the family, and then if the patient has whatever be the good for the patient, we should do that. And the overriding principle in ethics is autonomy, that is respecting the patient wish. So we should consider the patient as a person, not as a case. So these are some points that we have discussed regarding this patient. Thank you for your patient listening. And our next session will be on next Friday, not this Friday.
Yes, this Friday.
28. So 28 will be our next session.
And thereafter, this coming Friday, and thereafter will be every Friday, only every Friday.
So
29th, okay. 29th.
I request all of you to please join for every session. We have total 18 sessions, and in order to get certificate, you have to attend at least 15 sessions. And if you are unable to attend any session of the remaining 3, you have to first watch the video and please send us a feedback regarding the video in 200 words. And there will be assignments which will be sending to you from next session onwards. So all those who complete this criteria will be awarded with the TIPS Foundation course in palliative medicine. So this course is essentially for doctors. I know that there are some other palliative care or who are interested in palliative care has also joined. So they will be given participation certificate. Thank you
all very much. Thank you.
Stop here today.